This video is going to be on bone pathology. Now let's see what can go wrong when we're making our bone. And we'll start all the way in the beginning. If you recall, one of the ways we make our bone is through endochondral ossification. That's making that cartilage blueprint and then turning it into bone. And so if something goes wrong with our cartilage, or what our cartilage is made out of, collagen and proteoglycan, mainly collagen, something goes wrong with that, then we can't really make that bone. So problems with cartilage can cause problems with bone. This includes things like achondroplasia. There's an autosomal dominant disorder that has full penetrance. That means anyone that has it will show it. So full penetrance, and what does it do? It's a mutation in your fibroblast growth factor 3, FGFR3. And it actually activates this growth factor and inhibits chondrocytes. Chondrocytes are what make your cartilage. And if you inhibit chondrocytes, then you don't have cartilage. And you can't really make that bone the way you want it. So you have decreased endochondral ossification. Now, is that the only way you make bone? No, we said certain bones, like the flat bones in your face, your skull, your clavicle, don't use that method. And so these patients will have basically a normal size head, but short limbs, because that uses endochondral ossification. Now, is there a poor prognosis with achondroplasia? Not really. They have a normal lifespan, normal intelligence, normal fertility. They go on living normal lives, become stars of Game of Thrones. So achondroplasia is just more the shortening of the limbs. Let's move on. Next is osteogenesis imperfecta. Again, this is a problem with making cartilage, in particular the collagen part of cartilage. So osteogenesis imperfecta is a problem of making type 1 collagen. And so you get brittle bones. You get constant fractures, especially when you're young, and this can look like child abuse, so you have to rule that out. Also, this type 1 collagen is found in your eyes, and if you have deficient type 1 collagen, then you can see the veins behind your eyes, and they'll actually make your sclera look blue. So that's another sign, blue sclera. Another thing, you have defective bones in your ear, your middle ear, so you can have deafness. And then lastly, the bones, your teeth. You can have your dentine showing, so there's brownish discoloration. So I'll just say brown teeth. You see all this, you're thinking osteogenesis imperfecta. All right, so those are more inherited defects in making bone. What if you don't have those? What if you can make normal bone? Well, congrats for you. However, just because you can make normal bone doesn't mean you'll always make that. Your bone, like we said, is not only a reservoir for things like calcium, but it also needs calcium to mineralize and make bone. It needs calcium, and calcium binds with phosphate, kind of deposits in your bone and makes bone. Okay, so you need calcium, and the thing that controls calcium is vitamin D. That increases our gut reabsorption of calcium, stops it from being wasted in our renal tubules, so that increases calcium. So vitamin D increases calcium. Now, what happens if you have a deficiency in vitamin D? Well, you'll have deficiency of calcium, you'll have poor bone formation. So even if genetically you can make good bone, if you don't get vitamin D, you're going to get poor bone formation. And if adults don't get enough vitamin D, we call it osteomalacia. Malacia means softening, so softening of bone. If kids don't get it, if kids don't get enough vitamin D, we call that rickets. So I'll just write rickets and osteomalacia. So get your vitamin D. Milk is usually fortified with it. You can just go out in the sun and sunbathe. Don't sunbathe too long. But if you don't do those, or if you have a defective liver, because liver helps hydrolyze vitamin D, or you have a defective kidney because kidney also helps activate vitamin D, then you can have vitamin D deficiency. And your bones won't form the way you want it to, especially as a kid. So what are some signs of this? You can have chest cavity deformity, so you can have pigeon chest. Probably the biggest and most recognizable thing is bowed legs. So genu I don't know. I don't know. I'm demonstrating. You can't see my legs. So they look like this. This is the patient. So they're bent outwards. Varus. This is a side note. A friend told me how to memorize varus and valgum. Varus sounds like far, like your knees are going far apart. That's the way I memorize it. And then the other one is the other one. So just memorize one, and the other one's the other one. Shout out to Golden. So you get bold legs. You can have these malformed deposits of bone on your costochondral junction and your ribs. They make it look kind of like rosary. So we call that rachitic rosary. So all these physical signs, physical examination signs you see just from a lack of vitamin D and a lack of correct bone formation. What are some signs you'll see on laboratory? Well, in labs, you're gonna have decreased calcium. And what happens when your body senses that decreased calcium? It'll raise PTH to kind of raise that calcium back up. And that's not good because that just breaks down more bone. Also, something you should know about PTH. PTH really increases your excretion of phosphate. So you're gonna see low phosphate. You just excrete it all out. Why does it do that? What's the function of PTH? Increase calcium in your blood. And you want that calcium to stay in your blood. You don't want it to bind and go back to your bone. That would defeat the whole purpose. Then you'd have to break it back down again. So it knows that calcium likes to bind to phosphate and goes back to bone. And so it separates the two. It breaks down calcium and it excretes phosphate. It's like separating two troublemakers. You want to put them as far apart as possible. So PTH breaks down calcium and then separates phosphate so they can bind and basically become bone again. So just know PTH is commonly referred to as phosphate trashing hormone because it really trashes your phosphate levels, really decreases them. And lastly, your osteoblast will make a heroic effort and try and make bone, even when they really can't, but it'll try, and it'll release a lot of ALP. Call that the enzyme that helps mineralize bone. So those are your lab findings. Hope that makes sense. Let's move on to our next topic. Let's keep in mind that PTH breaks down bone, gets rid of phosphate. What happens if you have abnormal PTH, uncontrollable PTH, like if you have a PTH tumor, a tumor in your parathyroid and it's secreting a ton of PTH? Well, then your bone's gonna break down just non-stop. And it's gonna cause these cystic spaces that gets filled with fibrous tissue. You might have blood collecting in there that deposits hemosiderin and it turns brownish. We call all this brown tumors. And all this because you have increased uncontrolled PTH. We call all of this osteitis, fibrosa, cystica. You're basically causing fibrous cystic spaces in your bone. Now let's see if we can figure out the labs, especially if you have a primary parathyroid hormone tumor. If you have a primary tumor that is secreting uncontrollable PTH, you have high PTH. What will happen to your calcium? It'll increase. You're just basically breaking down all the bone you have, increasing that calcium. How about your phosphate level? What does PTH do to your phosphate? It excretes it, so you're gonna have decreased phosphate. And then your gallant osteoblast will try and make as much bone as it can, even if it doesn't work well. It will try, and so you have increased ALP. Those are your lab findings. That is osteitis, fibrosa, cystica. We're going to continue our talk on poor, brittle bones. And our next topic is osteoporosis. Osteoporosis is just decreased bone mass. Commonly seen in older patients. You want to start screening them, usually at around 65 or younger if they have risk factors. Risk factors include being underweight because you're not putting as much stress on your bone and your bone doesn't grow. White or Asian ethnicity, smoking because smoking causes everything. So those are all risk factors. Those are all risk factors, so we want to start screening them. And we screen them with what we call a DEXA test, or a DEXA scan. This is basically a scan that compares your bone density to a normal person. So we'll give you your standard deviations if it's between 1 and -1. Right here, 1 and -1, that's considered normal. So you're within that standard deviation, but if you start to fall further away, if you have less and less bone mass than normal, then from -1 to -2.5, that's called osteopenia. You're at risk. And then anything over -2.5, you have full-blown osteoporosis. So you have thin, low bone mass. Usually affects your trabecular bone. That's your spongy bone. And usually chronic, so you see this in older patients, they kind of slowly decrease bone mass over time. And because it's slow, your body gets accustomed to it. So lab finding is usually normal. Very important, you know that. But eventually your bone mass will decrease into a point where you just get pathological fracture. So you fracture in situations where you normally wouldn't fracture a bone. So if I fall from this height, I shouldn't fracture my bone, but if I had osteoporosis, I might. Common sites are your vertebral column. So the spine, you can have stress fractures that can cause pinpoint pain. They'll talk about pain in the back, and if the doctor presses on a particular point, the pain, that's pinpoint pain. So that's a fracture there. They might start having kyphosis, so stooped over, loss of height because of the fracture. We never want to get to this point, so we want to prophylactically help them out. Weight-bearing exercise is good. When you put weight on bones, they'll increase stress on bones and your bones will grow. Know something, swimming is not weight-bearing exercise. In fact, swimming is probably the reverse of weight-bearing exercise. You're kind of losing weight when you're in the water. So know that that's not it. I had a question on that and I put that and I got the wrong answer because I realized then that swimming is not weight-bearing exercise. So try and get them to lift some weight. Try and increase vitamin D and calcium just to try and build some more bones. And those are kind of prophylactic measures. Causes, we talked about how decreased estrogen can cause it. Old age can just cause it just because you have decreased bone mass. Don't forget causes like drugs. Corticosteroids are commonly known to cause osteoporosis. Corticos, and also PPI, that's another one a lot of people forget. So those are your proton pump inhibitors, changes in your acid balance. The exact mechanism of why it causes osteoporosis, I'm not sure, but always remember PPI. And then anorexia, because you lose so much body weight, you stop menstruating, you have amenorrhea, and you basically go into menopause and get osteoporosis. So I'll just write amenorrhea / anorexia. Those are all causes. Now, how do you treat it? Well, we have drugs for that. First line drug is bisphosphonate. These all end in dronate. So the drug name should be easy to remember. So bisphosphonates bind the bone and they inhibit your osteoclast. All right, inhibit osteoclast. By inhibiting osteoclast, you kind of slow down that resorption. Some side effects that you absolutely need to know for bisphosphonate is kind of nasty. It's very corrosive. It'll cause your jaw to basically corrode away. You'll see osteonecrosis of the jaw. It'll cause your esophagus to get inflamed. You get esophagitis. So you always tell the patient, drink water with it and stand upright for 30 minutes. 30 minutes. That way it can kind of go down. If you lay down and it just kind of bathes there, then it'll make things worse. A lot of questions I'll see on it is someone will have osteoporosis. They might not say osteoporosis. They might say DEXA scan over -2.5 standard deviations, blah, 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 all this stuff. Vertebral fracture, so just beats around the bush, but they mean osteoporosis. The patient has osteoporosis, given a drug, develops osteonecrosis of the jaw. How could it have been prevented? Water, stand up for 30 minutes. So that's a common way you like to ask side effects of bisphosphonate. And that is a side effect you absolutely need to know. Because these are common drugs, you're probably going to give it to someone at some point in time, and if you allow them to develop that, they'll probably be very upset with you. So no bisphosphonate. You can have another drug is teriparatide. Teriparatide is a PTH, synthetic PTH analog. It shouldn't surprise you now. We said that PTH at certain levels can increase bone building, so this is the basis of PTH. So it builds bone. And this drug is actually good because a lot of drugs we use for osteoporosis stops bone inhibition but doesn't really build bone. So it just slows the progression but doesn't really kind of help you or reverse some signs. So this one actually builds bone. But can you tell me what can go wrong? If you're constantly building bone and creating that bone turnover, then it increases your risk for bone cancer. And the recommendation is you don't put patients on this for too long. Usually you can start patients on this and then transfer over to bisphosphonates. Other things, hormone replacement therapies or selective estrogen receptor modulators, things that basically give you more estrogen or bind estrogen, and that just stops osteoporosis because we say estrogen inhibits rank L. Well, this will just do the same thing. The SERM you need to know is raloxifene. Last drug, denosumab. So denosumab is a monoclonal antibody, that's the mab part, against rank L. And by blocking rank L, you block osteoclast differentiation. That is your osteoporosis. I think I'm getting kind of tired of talking about decreased bone mass. Let's talk about increased bone mass. Ooh, that'd be cool. So let's talk about some disorders of increased bone mass. We can talk about something called osteoporosis. I actually got a question wrong because I misread it as osteoporosis. Osteoporosis. Now, how does your osteoclast break down bone? Do you remember? Produces collagenases, also produces H+. Produces H+ through an enzyme called carbonic anhydrase. Kind of pumps out that H+, and that dissolves our bone. If something goes wrong with that carbonic anhydrase, then it can't pump H+, and it can't break down bone. If it can't break down bone, bone just kind of builds and builds and builds and builds. And you get thickened bone. And that sounds really good. It sounds like you're like a superhero. You have thick bones. But that bone is not normal. Yeah, that bone is actually fragile. All right, fracture. Not only that, but that bone, if this is like our femur. All right, this is almost femur. We have our bone marrow right here. Eventually, if you have osteoporosis, that bone will grow and grow and invade into that bone marrow and basically take it out. And so you have pancytopenia. Can no longer make cells. So your body will try and make cells elsewhere, especially red blood cells. So you get extramedullary hematopoiesis. And the main sites of your spleen and your liver, those are your earlier sites of making red blood cells. When you were an embryo, you didn't have bones. So you didn't have bone marrow to make red blood cells. So your spleen and your liver actually made it before your bones. And so when your bone marrow goes out, your spleen and liver wake back up and say, oh no, I gotta make more red blood cells. So you get extramedullary hematopoiesis. Usually shows up as hepatomegaly, splenomegaly. Something else you can have, once these bones grow really thick, they can impinge on cranial nerves, so you can have cranial nerve problems. Labs, if it's mild and it's slow growing, then there's no really change in labs, so no lab changes. Eventually, if it grows more and more aggressive, then you'll have decreased calcium. Why do you have decreased calcium? Because when osteoclasts dissolve bone, they release calcium. If you can't dissolve bone, then you can't release calcium, so you have decreased calcium in your blood. That's osteoporosis. Let's talk about Paget's. Paget's is this disorderly bone formation that causes thickened bone. Disorderly formation. So there are a few stages. Stage 1 is lytic, meaning breaking down. So what cell do you think takes place in the lytic stage? That'd be your osteoclast. Next is mixed. So both of them jump in for the fun. You start to build bone and kind of break down bone at the same time. And then next is sclerotic, which is just your osteoblast building bone. And then last is your quiet stage, where you don't have any bone formation. The culmination of which causes disorderly bone formation and thickened formation. you have thickened bones. I have a picture in my slides of someone that has really thick skull bones. That is Paget's disease. Now, patients might not just come in and say, "Doc, I have a really thick skull bone, can you help me out?" They might instead complain of things like increased hat size. That's a common complaint. Increased shoe size because their foot just gets so large. So what? Where'd that F come from? Shoe size. And some labs. Something peculiar you'll see in labs is osteoblast activity will really rev up because you're causing thickening of bone. So you're gonna have elevated ALP. Sometimes that's the only finding you'll have. If you have signs of increased hat size, increased shoe size, and isolated ALP, then that is Paget's. Some treatment, you can give bisphosphonate or you can give calcitonin. Why these drugs? Bisphosphonate inhibits osteoclast, calcitonin inhibits osteoclast. Osteoclast is your first stage, so you kind of just start from the top. So bisphosphonate and calcitonin is used for Paget's. That does it for making and breaking bone. Let's talk about some general bone pathology. You can have infection of bone. We call that osteomalacia. What are some symptoms? You're going to have systemic symptoms of an infection, so fever, increased white blood cells, all that stuff. Systemic symptoms, but you know it's a bone infection because you have bone pain. Now, what image would you want to order? A lot of times when you hear bone, you kind of jump to X-ray, but MRI is actually the better choice in the acute setting. MRI acute. Because a lot of times it picks it up better, first of all, and also when you have bone infections that can invade into your soft tissues, and MRIs are better for that. However, X-rays can be used a little bit later on. X-ray can show things like abscesses. We call that sequestrum. Basically, it looks like bacteria has sequestered into a spot. You get this little lytic lesion. And also the pus around the sequestrum will erode around the bone. So the outside will kind of erode, and your osteoblast will try and come in and make more bone. That little ring you see is called the involucrum. So you can see that on X-ray. Where does it affect the bone? Well, in kids, it's usually the metaphysis. Why the metaphysis? Because bacteremia is one of the common causes of osteomyelitis. That's bacteria going in your blood. And your metaphysis has the most blood vessels. So kids get it in their metaphysis. Now, the bugs that cause osteomyelitis depends on the situation, and I'm not going to write them all down. I want you to know something. Anytime you see associations, what do? You think of everything you know about that association, and you synthesize it in a step-like question. Right? Don't just memorize it. Don't just memorize that dog bites and cat bites can cause osteomyelitis from Pastorella. Think of everything you know about Pastorella and then try to synthesize it into a question. How would they ask that? They'll talk about a kid that gets like a dog bite and then develops bone pain, elevated white blood cell, fever. And then if you culture it, what would you find? That'd be a good question. What do you find in Pastorella? It's a gram negative, it's oxidase positive. So think of it like that, okay? That's how you gotta think about it. Don't just memorize that list, okay? It's not gonna appear like that on the stem, on the question stem. It's not gonna say a kid got bitten by a dog and developed osteomyelitis. What's the causative agent? Because then everyone would get like a 260 if it was that easy. So always think of everything you know about association and then synthesize it into a step-like question, okay? So that is a little rant. I'm gonna go move on into my next and last topic, osteonecrosis. That is infarction of the bone. How will that present? It will present with bone pain. One of the most common sites is going to be your femoral head. In particular, what supplies it is your medial circumflex femoral artery. I actually got a question on this. Medial circumflex femoral artery supplies your femoral head. Why is it a common site for osteonecrosis? Because it's retrograde blood supply. What does that mean? If this is tissue and there's a blood vessel, and it goes right to your tissue. That's anterograde. That's where it's supposed to go. Retrograde goes past and then comes back. That's an extra step. That's more complicated. That's just kind of a worse way to do things. So retrograde blood supplies are at increased risk of necrosis. Just so happens that this one goes retrograde. Complications, well, it won't heal as well. So if you get a fracture, then it just won't heal. You'll just have constant pain. We call that osteoarthritis. All right, so those are some complications. That does it for this video. Hope you enjoyed. Hope you paid attention to my rant. Thanks.